It's early on Sunday morning, but it is after 9 o'clock, so why don't we get started? Good morning, everybody. Thank you for being here. It's really echoing in my ears. Do I need to stand back a little bit? This is fine. My name's John Balbus. I'm the Senior Advisor for Public Health at the National Institute of Environmental Health Sciences, and I also direct there a WHO Collaborating Center for Environmental Health Sciences, and it's my pleasure to welcome you today to this concurrent plenary session on the health implications of climate change and environmental degradation. We have a wonderful panel. I just want to start by thanking Keith Martin for bookending, if you will, this wonderful conference with sessions that are addressing the implications of climate change for global health. I think if you've been part of the sessions that we've had so far, and there have been sessions throughout the course, you see that the kinds of issues that we're talking about, the role of a stable climate as well as the role of environmental exposures, really touch on almost everything related to global health, even issues that seem as disparate as HIV/AIDS and tuberculosis and other infectious diseases, which are so impacted by the social determinants of health, by social migration, by economic well-being, which in turn are very much dependent on the stability of the environment we live in and the resources we get there. I wanted to just start, I gave you my title, but I also want to tell you that I'm a father of 2 grown daughters who themselves actually want to have children. I'm a bicyclist who, since I was a young boy, always loved the outdoors and lived in wonder and awe at our natural environment. I'm a physician who was very fortunate, at least towards the end of my medical training, to come in contact with wonderful mentors who told me that I can combine concern about social justice with the care and healing of people. And of course, it's impossible to address the climate crisis without also addressing social injustice in its many forms. I start with this because I think it's really important to be honest with ourselves and to identify the values with which we come to this. We're going to be hearing evidence, we'll be hearing data, we'll be hearing science, but part of our session today is about why we should be acting and why the entire global health community needs to be concerned about the climate crisis and environmental degradation. And I think that we need to be honest with ourselves about our values. I think that by having this honesty, we can find the motivation we need to avoid complacency, which we all have to one degree or another, as we realize the gap between what we want to see, what we want to be doing ourselves, and what we have been doing. And it's also critical for us to be open and upfront about our values if we're going to have the kind of dialogues that we heard from Jeff Lewis in the beginning and actually are listening to each other. We have to ground that in the values that we express and the values that we share. So with that as a start, I'm going to very quickly introduce the wonderful panel we have, and then we can jump right on in. We have, again, a wonderful lineup of speakers. We'll be hearing, first I will give a brief presentation, then we'll be hearing from Dr. Madeline Thompson, who's a senior research scientist at the International Research Institute for Climate and Society, otherwise known as IRI at Columbia University. Everybody's short bio is in the app, so I'm not going to read the entire bio. If you don't have the app, if you decided to forego that, you can turn to the person next to you if you want to find out more about our speakers. Our third speaker will be Dr. James Hospitalis, who's the Executive Director of the Caribbean Public Health Agency based in Trinidad and Tobago. Our fourth speaker will be Professor Wim de Villiers, who's the 12th Rector and Vice Chancellor at Stellenbosch University in South Africa. And then our closing speaker will be Dr. Kim Knowlton, who wears a couple of hats. She's the Senior Scientist and Deputy Director of the Science Center at the Natural Resources Defense Council and is also an Assistant Professor of Environmental Health Sciences at the Millman School of Public Health at Columbia University. So with that, I'm going to set the timer on myself. And what I'd like to do in the next 12 minutes or so is just give you a kind of whirlwind overview of why this is a time for action. What are some of the things that we can say about climate change and its health implications, and a little bit about what's going on within the international and global health space in terms of finding the solutions. So again, I come from the National Institute of Environmental Health Sciences. Just my home institution is part of the National Institutes of Health. So I speak from a biomedical research perspective. So 2017 was a pretty remarkable year. It actually was the most costly year for natural disasters in the United States, and I think we all have been feeling the extent of the disasters. This is a picture not of the 3 devastating hurricanes that struck the United States. It's only one of them because they weren't all on a satellite image at the same time. But this is Tropical Storm Katia, Hurricane Irma, and Hurricane Jose. We're not showing the bookends, Harvey and Maria. But hurricanes were devastating to the United States and especially devastating to the small island states of the Caribbean, as we'll see in a little bit. Of course, hurricanes are not limited to the Caribbean. We know that the Asia-Pacific region has been devastated in the last 10 years by more severe hurricanes. When we talk about extreme events, it's not to say that we would not be having these extreme events without climate change, but we know that the oceans, which have been warming and absorbing a lot of heat for the last several decades, are the energy sources of hurricanes. And so the hurricanes that are occurring are being observed to be more intense, more severe, higher winds, sometimes higher precipitation rates. And we saw that in the Caribbean when we had multiple Category 5 hurricanes, which is a very, very rare occurrence. So again, this is not the only manifestation of climate change, but it's a climate change exacerbated situation. And it's not just wetness, right? It's also dryness. So this is another satellite image showing the places on the planet that were burning at one time. We know that 2017 was a year of devastating wildfires in the United States. We're seeing an increasing trend in the number of acres burned every year. And we know that ambient air pollution is a significant cause of death and morbidity around the world, with over 3 million deaths every year from ambient air pollution alone. And we know that the wildfires are a major cause of this in places not just in the Northwest or the Western United States, but also in some of the Pacific areas, Indonesia as well. And these are not all wildfires naturally occurring, so to speak, or caused by drought and accidents and lightning. A lot of what you're seeing there is actually deliberate agricultural burning. All of this, though, is contributing to health impacts. So this is hopefully you guys can read that. Okay. This is just a depiction of the severity of this past year in terms of extreme events, to give you the sense that this is not just happening in one place, and it's also not just happening in Russia or the United States or more developed countries, but it's actually serious and severe impacts in places like Sierra Leone, where there were deadly landslides, in places like the floods in Pakistan that have occurred. So I'll let you read that. I'm not going to go through it all in detail. But this was, again, just to make the case that if there were to be a clarion call, the kind of severity of the extreme events give us a sense of how people's health is connected to their environment, even as we're seeing longer-term impacts of climate change as well, in terms of water supplies, heat waves, and other kinds of phenomena. And again, I show you this slide just to make the case that, and in a very important case, the distribution of these events is worldwide, but the burden of illness, disease, and death from these events is not distributed equally. That disproportionately, the countries that have the least resources, the most people in poverty, are the countries that have the highest burden of illness and death. And this is just showing the disproportionate amount in 2017 of fatalities that occurred in Asia relative to the types and events, numbers of events that they experienced. Just checking my timer. So those are the extreme events, but I wanted to show this to you to give you a perspective of what climate change means in terms of the average temperature of the planet. This is a spirograph showing the monthly temperatures. You could see it started in about 1865. And we know that the natural climate is very variable. We know that year to year we're going to have warm winters, some years cold winters, other years. But the nature of climate for most of human history has been to vary back and forth within a limited range. And you can see that limited range here at the start of it. There are warmer years, but the variation there is within about a half a degree Celsius. And you can see the phenomenon we've been observing now over the last 20 years or so. And I'll let you see it again, where we've broken out of that range. We've broken out of the variability that we had been seeing. That was, I don't have a spirograph that can take you back to the Ice Age, but from the paleoclimate records that we have, for the most part, the temperature was varying within a half a degree, sometimes an excursion of 3/4 of 1 degree Celsius. But you can see here that we're almost at the 1.5 degree range, and that it changed each year. And what you've all probably heard is that each successive year that we're seeing is in the top 10 years or the warmest year that we've experienced. So this just gives you a visual idea of the absorption of heat the planet has had and how that manifests as just the average surface temperatures. What does this mean in terms of human health? Very hard to give you the full litany of and the full variety of health impacts that are associated with extreme climate variability and climate change. But I thought this infographic from the British Medical Journal did a nice job. And if you go there, it's actually very interactive, and you can find out more about each of these impacts. The case I wanted to make with this pretty complicated slide, they are dividing the types of health impacts that are associated with climate change into 3 categories based on the way these health impacts were categorized in the latest Intergovernmental Panel on Climate Change report, the 5th assessment report. And you can see that they talk about direct impacts, and the idea is that we have storms, we have heat, we have changes in solar radiation. These are direct physical impacts on people's health from the temperature, from the energy of the storms, from the solar radiation. Another category are considered indirect or ecosystem mediated, so things like ticks, mosquitoes, other kinds of critters that transmit disease, bacteria, other pathogens are very temperature sensitive, and so changes in temperature, changes in precipitation may change the transmission of those diseases, may make food and waterborne diseases more common, those kinds of things. And then they have this third category that's human system mediated or human institution mediated, and this is where they categorize things like the cause of climate-induced migration and the health problems of environmental refugees, or the mental health and stress impacts, which I'm not exactly sure why that's human institution mediated, but it gets put there. Occupational health, because we are in working systems. The case I want to make to you, and the reason why I think this is an important thing for this global health community to hear, is that in some ways all of these health impacts are human system mediated, because all of these impacts can be made worse or better by the governance that we have, by the regulations that we have, by the policies that we have, and very much by the kind of health systems we have in place. And that's what I'm going to be closing by talking to you about. So even things like floods and storms, much of the burden comes after the flood and storm. It's not the energy of the storm that kills people, it's often the lack of access to health care, or it's the failure of water and energy supplies that happens after the storm. Even a heat wave, it's the failure of providing adequate cooling, adequate protection to workers. Very much everything is mediated by human institutions, and we have a lot to do to control that. And so this is a slide that we had from our US climate and health assessment, and again, it's a little bit busy. It's showing the exposure pathways down the middle, the various ways that climate, that heat and storms and precipitation connect to the things that cause human disease, like mosquitoes and ticks, like extreme temperatures during the day, like air pollution. But you can see to the left is an environmental and institutional context, and then the social determinants are all mediating factors. And because of time, I can't go into more detail on that. But what I wanted to impart to you is that there is a solution space that touches on all that we do. There are many different solutions, but I wanted to highlight what we can control to get to this goal of sustainable, healthy communities in the middle. And there are sustainable, healthy communities that need interventions in developed countries, and certainly we need sustainable, healthy interventions for sustainable, healthy communities in the developing world. So just to go around this very quickly, I've used the term climate-ready health systems to convey the idea that health systems need to be resilient in the face of extreme events, and they need to be prepared for the kinds of shifts in infectious diseases, for the kinds of changes in morbidity and mortality that we see in heat waves, to be prepared for the kinds of health implications for the shifts in people, the shifts in diseases that we're seeing because of climate change. I distinguish that from climate-smart healthcare facilities because part of the solution space is actually the role that we have in the health sector to reduce our own greenhouse gas emissions, to reduce the carbon footprint, to assure that the way that we build facilities is energy sensitive, that we're using renewables as much as we can, because there is this need to have both sustainable and resilient healthcare facilities that are able to continue operations even in the face of increasingly extreme conditions, whether that's flooding, temperature extremes, or extreme hurricanes. Green energy solutions are, of course, part of the solution for the entire planet, and I put this up there because, as we've heard already, we have 7 million people dying because of indoor and outdoor air pollution, and the vast majority of that air pollution is coming because we burn things for energy and for all, well, basically for energy. So we need to find another way to generate the energy we need that doesn't cause this kind of huge burden of death and disease. There's a broader set of built environment solutions because the world is moving towards less and less physical activity as it uses more and more motorized equipment, which is using more and more intense energy. And there's my bell. And then the last is the social determinants. What I want to do in the last minute that I'm going to use is to tell you some of the things that are going on around the world. One very encouraging sign is that the Belmont Forum, the consortium of research institutions around the world working on climate change, are taking up research on climate change and health. These are the first set of topics. We're in the process of designing this call for applications over this coming year. It will be coming out in the fall, and in the next year or two, there will be increasing opportunities to fund research. And you can see it's a very diverse array, everything from the use of energy and air pollution to food systems, to disasters and environmental migration. The WHO has taken up this issue of climate resilient and climate ready health systems. And it's a complicated wheel. It has many different components. I wanted to put it up there to show you it's not just about being ready for pandemic threats. It's not just about patient surges in heat waves, but it's about health information systems. It's about sustainable technologies. It's about improving data collection, and especially about finding finance for improved health resilience, and also building the workforce and building the capacity of the workforce. The World Bank has really launched into a much more focused effort to make sure that their investments in healthcare are also climate ready and climate smart. They have a number of really wonderful documents. They have a new algorithm for going into countries and assessing the readiness of a health system for climate change, and they are guiding their investments in the future by looking at both the resilience and the hardening of the facilities, the continuity of operations, but also looking at things like their energy supply, their use of sustainable materials, et cetera. I wanted to just let you know about a program that we have at NIH that is looking at this nexus of extreme events and understanding how disasters and extreme events are exposing people to chemicals, are exposing people to other kinds of threats, and what are not just the immediate implications of that, but the longer-term implications for various kinds of health impacts, whether that's loss of access to care, mental health impacts that are prolonged for many years, et cetera. And lastly, I just want to share with you a resource that we're developing at NIEHS. It's a very comprehensive climate change and health literature portal. We are coding and categorizing as much of the literature on climate change and disasters and health as we can. You can see the URL at the top, and I just urge you to take a look at it. And with that, I'll close, and we'll move on to our next speaker. And we'll look forward, if everybody can stay even more on time than I, to a nice Q&A session at the end. So thank you for your attention, and now we'll hear from Dr. Thompson.
So, thank you very much. I'm very pleased to be here this morning. I have a task in my allotted few minutes to tell you something about a meeting that we were engaged in earlier this week. And it was part of the satellite session here at the Hilton on Thursday. And it focused on climate change and the health priorities of vulnerable populations. And John has just given a fabulous overview of the sort of huge space that we have when we think about climate and health, whether it's thinking about adaptation or mitigation or just really understanding the impacts. And we wanted to take a bit of a focused lens on some specific aspects through our workshop, which was a 4-hour workshop, which I'm going to sort of render to you in a 10-minute about 10 minutes. So the sponsoring organizations was NIH with John and Jonathan Patz from Wisconsin, my own institute, the International Research Institute for Climate and Society, and Columbia Medical Center. Now, my own institute is actually a bit of an oddball institute at Columbia. It brings climate scientists together with sectoral specialists. So my own background as a health specialist, I was originally trained as an entomologist working in Africa, and I lead the health work at the IRI and also direct a WHO collaborating center on malaria early warning systems and other climate-sensitive diseases. So that puts a little bit of background to the context of the meeting which we developed. And we had 3 panels. I must admit, it was a very energizing meeting, bringing together very different lenses, but I would say in a very coherent way. The first one was around extreme events and children. And here, the panel was made up of pediatricians who'd been engaged in the response to hurricanes in Puerto Rico and in Texas, flood risk in Pakistan, and heat waves particularly, but all looking through it at the lens of children and as the vulnerable population. And I think that made a very different take on what was necessary in order to develop an appropriate response. It's no good turning up with your response with medical interventions that are suitable for adults but not suitable for 3-year-olds. Looking after children in an emergency when they're separated from families is a very different situation from separated adults. And the session itself, I think, just really highlighted the need that when we talk about vulnerable populations, we have to really know who they are, where they are, how they live, and when disasters strike, what are the multitude of linked responses that need to happen in order to give them protection. And the key messages, I think, that came out of this, and I must admit that my eyesight is not good enough to read my slides, so I hope I get it right, is that there are lots of commonalities for all of the disasters that were discussed in the relationship to children. And the primary thing is, like, children are not small adults. You cannot see them as just being recipients of generalized care. They may have the same moral standing as adults, but they don't have the agency and the responsibility for the adults to take legal and social, emotional, and medical care of children is obviously primary. And that impact on children can be multi-generational. We discussed a little bit some of the impact on Katrina, which are still being felt. Children that were held back in school, children where their social and family life was completely disrupted and remains disrupted years after the event. And we've seen in studies, I know in Ethiopia, where disasters and health emergencies result in poor schooling, poorer life chances, marriages at a very early age, and a whole cycle, if you like, of deprivation that comes from extreme events, not only in the developing world, but also here in the US. Our second panel was more of a technical panel, and it brought together the skills of my own institute, the International Research Institute for Climate and Society, with the Mailman School, and also the Clinton Health Access Initiative. And there, the focus was really on, well, we talk a lot about climate and weather events, seasonal predictions, climate change predictions, but what do they actually mean in terms of health response? Do we have a workforce that actually understands enough about how the climate functions to be able to respond when the climate scientists, the weather forecasters, the seasonal predictions, etc., come in and we have a sort of suggestion that this is going to happen in a particular area. So I'm going to spend a little bit more time on this session. And we all like to be able to look into the crystal ball and forecast the future. We know that the future is not that forecastable on all sorts of fronts, and climate has its own challenges. It's a chaotic system, weather is chaotic, but there are underlying rules, if you like, that allow us some predictability. And in today's age, the power of computing is extraordinary, necessary, if you like, in terms of resolving what the weather and climate are doing and how that information can be made available to society. So this is one of the supercomputers at the UK Met Office for their weather forecasting. Supercomputers are the basis of our modern weather forecasting and climate forecasting activities. So we need to have that capability, but we also need to understand that there are lots of things you can forecast without having a supercomputer, without even knowing very much. And I have colleagues at the moment in the Rohingya refugee camps in Bangladesh, and in fact I got a text from them this morning saying, MSF is setting up cholera reception sites because of the fear of the rainy season. They're not worried about an unusually wet rainy season. They're just worried about any rainy season in a situation like this with a highly vulnerable population where there is completely inadequate services and an inadequate environment to manage any heavy rainfall whatsoever. So there are lots of things we just know are going to happen, and we need to take action immediately. But we also need to understand what we can predict in the future, what we can't predict effectively, and how we need to organize around that. So this slide, and I'm maybe a little technical, but I'd just like to you to bear with me for a minute. It's saying how good are the different types of forecasts at the different timescales that we have available. And if we set the bar looking at weather forecasts, which we all have experience of, we complain about the weather forecasts as not being perfect, but we use them all the time because we know they are pretty good. Yeah? They do tell us when a major storm is coming through. Can you imagine Sandy hitting New York without a forecast? Unbelievable if you think about that. And they have forecasts a week ahead of time to enable people to prepare. But weather forecasts, because of the chaotic system, are very good for the first week, and they tail off pretty quickly after that. And the next time scale that we have, where we do have decent information, is the seasonal time scale. In certain parts of the world, we have a pretty good heads up as to whether it's going to be a dry year, a wet year, a warm year, or a cooler year. And then we know from all of our knowledge of the physics of the climate and the observations that we have, these strong warming trends that we see all around the world. But we have some gaps. We have gaps and sort of weak areas. It's quite hard to say whether in a month's time, say May, the first week of May, is going to be unusually warm or cool. That's a difficult thing to forecast. It's also very difficult to say what is the 5-year are we going to have major droughts in 2030? That is also a difficult thing to forecast. But bringing together the information that we have, we can start linking that to actions on the ground. The first thing you have to understand, though, is that the information that we have is place and time specific. So weather forecasts, very good for the extratropics, for us in the north, and we are pretty good at predicting cold spells and hot spells, which gives us rise to heat wave early warning systems. Seasonal predictions are very good in the tropics because that is where the seasonal predictability in the world exists. And for rainfall, they're not so good in the extratropics where we are here. Seasonal forecasts for rainfall are not that good, but seasonal forecasts for temperature are pretty good all around the world. And we get a big bump in temperatures for a short time whenever we have an El Nino, for example. And when we look at climate change scenarios like these, which are the sort of standard format that you'll see coming out of the IPCC, the range of skill or the forecasts is very dependent on what we do, our actions. Yeah? So if we are able to mitigate the emissions, then we will go to a lower temperature in the future. If we are not, we will go to a much higher temperature. It's much harder to say what will happen with rainfall, and that's because of the complexity of the climate system. So I just want to, how am I doing? Move forward quickly on making this real at the country level. And one of the things we've been talking about using climate information for a long time, actually you need to get involved at the country level, you need to work with the national partners, and they have the data. The data is not available globally on the climate side. So you have to engage with the national Met services, and there we've seen that on the research side we can develop all of this information that connects climate to health outcomes, but on the practice side we need to embed that in local institutions, in local capacity, and that is a huge capacity building effort from the health community. So our last panel, and certainly not least, was focused on real opportunities that come out of discussing climate change, and the first one, of course, is the co-benefits of climate change mitigation, the fact that we can forecast activities and that we should use those, and that we can develop early warning systems around that. So that was the conclusion from the second panel. I'm sorry, yeah. The third panel basically focused on the co-benefits, the need to protect vulnerable populations, and recognizing the value of ecosystem and climate services as a support to health systems. And finally, we had a very powerful call to action from Ed Maywach, who really was looking at the Paris Agreement, and everybody who signed up for the Paris Agreement, which was a huge achievement on the political front, recognizes that the emission standards, the emission reductions that were put into the agreements are not sufficient to maintain global temperatures below the 2 degrees or move them down to the 1.5 degrees. So the end of our session came with a call to action, which was very much, for those of you who've been to see the recent movie on Churchill and how the framing of getting action across communities in a powerful way, the time to act is now. The decision, the sort of humming and hawing about what we're going to do is over. It's really the time to act is now. And there are so many organizations on the health front that are moving forward to build an alliance around identifying health, particularly as the outcome that will mobilize the public towards climate change mitigation. And he set a call to action, and I hope that you will respond to his email to join in the community of health practitioners, health policymakers, health researchers that really drive the climate change agenda going forward. Thank you.
I'm a physician, public health physician. I'm the director of the Caribbean Public Health Agency. I'm a father, starting like you. I have 3 kids. One of them is married to a guy who's in New Jersey next door doing his internship. And when I was a kid, I grew up in Trinidad in a semi-rural area. I kept a lot of tropical fishes, thousands of them. And if you keep tropical fish in a large container or hundreds of gallons, if you don't contain the population, the environment degrades, and the fish eventually all die. And it's like a little microcosm. And it seems we're sort of doing that to our planet, as much absorptive capacity as it does have. We have 24 countries that make up our organization. The median size is 100,000. So a lot of the countries are smaller than 100,000. And when you're smaller than 100,000, you have some real capacity constraints. Even though you may be like Bermuda with near $100,000 per capita income, if you're so small, it's very difficult to do everything you need to do. I hope they're changing over the presentation. I'm sorry about that. How many people here have been to the Caribbean? Keep your hand up. How many would like to go? That's almost everybody. So, it's when God made the world, I'm a Christian, I believe God made the world, and I also believe in science and climate change. When God made the world, he spent a little more time in the Caribbean than most other places. But we have some problems in paradise. It's a watery part of the world. As John pointed out when he spoke at our meeting last year, I thought, that's true, it's a watery part of the world. And if the climate is changing and the world is warming, there's going to be more evaporation, it's got to come down somewhere. If you're a watery part of the world, then you feel the brunt of it more than elsewhere, both in the storms, which is the most visible manifestation. And those storms, the thought occurred to me last year, our whole planet is an alarm clock, and those monster storms we're having in the Caribbean are the alarm going off to try to wake people up to pay attention and do something. And if we continue to not do something, it's just going to get worse, and folks like us in the Caribbean are particularly vulnerable. But it affects everywhere. The big storms in the Caribbean, California wildfires, Southern African drought, all of those are connected. The chipocalypse. Anybody heard of the chipocalypse? Blank. Look it up. It's New Zealand. They had 6 weeks of rain and non-stop, and it flooded out all the potatoes. So if you don't have potatoes, you can't have chips. Chipocalypse. So this is what my presentation is supposed to do, and I'll have to go fast now. This is a basin of the world, about 1 million square miles, roughly 1,000 by 1,000 miles. We have 40 million people. We have 50 million visitors. And it's very diverse, as I mentioned. We have an aging population with a lot of non-communicable diseases. There's pretty good education, communication, the economic sources, agriculture, gas, oil, financial services. And it's what's called an intermestic space in political science. Although they're independent countries, we're so small and we're so close together that it operates domestic. So my agency is an example of that sort of thing. We have 1,000 named islands and about 129 inhabited, as far as we know. And this was the birthplace of the SIDS movement, the Small Island Developing States movement. And a little bit of context also is my agency, which is headquartered in Trinidad and Tobago with 24 member states. Here we are in Port of Spain. That's our headquarters. And climate, John touched on this, so I don't need to go too much, affects health in many ways, both directly and mediated through a number of determinants of health. The physical environment, biological, social, and the policy environment are also all affected. Now, if we look at what's happening with climate and the Caribbean, I've put here a summary of some of the science from the group in University of West Indies, Jamaica, which has downsized a lot of the science about what it means for us. And in short, we have hotter, drier times ahead with more monster storms and extreme rain events. And that has profound implications for us: health, the economy, the environment. I had this slide earlier, didn't I? Paradise on Earth. But and because we're so dependent on tourism, we have a tourism and health program with the hotel and tourism industry and the cruise line industry for healthier, safer, more competitive tourism by attending to health and safety issues. We have some problems in Paradise. If you look at the top left, you see shanty towns on a coastal area. That's obviously going to be very vulnerable next hurricane or storm surge. Top right, you see poor housing on a hillside. That's vulnerable. Water insecurity, storm vulnerability, and because people store water, vector-borne diseases. Bottom left, riots over lack of water for drought. So all of our big hurricanes in the past couple of years have been attended by security events. So now our chiefs of security and commissioners of police this year, for the first time, will put on their agenda the anticipation and prevention of the security breakdowns that take place following hurricanes. And bottom right is human trafficking, people leaving in part because of the degradation of the environment. John showed this. This is Maria over Dominica, a very vivid image. But it wasn't only Dominica. Top left, British Virgin Islands. Bottom left, Peebles Hospital stood up pretty good. That's one of the new smart hospitals that was built to more resilient. So that's good. And bottom middle there is Mr. Branson, very unhappy that his private island has been devastated. I wouldn't say whose property I wish got devastated as a lesson, but your president has several properties in the Caribbean. Puerto Rico. Poor lady doesn't know what to do, and it continues to suffer. It's not only in the islands. If you go down north to Guyana, look at that interplay of climate and environmental factors. Top left, that's Bridgetown. Sorry, that's Georgetown, which is 6 feet or approximately 2 meters below sea level. So top middle is the seawall, the seawall, if you come from Guyana. And there you see top right, massive waves bursting over that seawall. Bottom left, the land was flooded for 6 weeks. a massive outbreak of leptospirosis took place. Bottom middle, part of the compounding factor is all the drains that drain the land were blocked by debris and rubbish and plastic bottles 15 feet high. So the water couldn't get off the land. And if you look at the bottom right, something interesting has happened. Those waves smashed the seawall. They had put an additional meter high on it. Those seawalls have been good for a couple of hundred years. The Dutch built them. But in the last 15, 20 years, the water has been coming over as the sea rises with increase in frequency. They really need to think about moving the capital. Related to storms and after storms, we have a surge in vector-borne diseases and in leptospirosis. This is a climate-sensitive vector and spreading up into the southern US. So we're sharing our problems. This is our 2016 Zika epidemic, and now we're dealing with the consequences of it, the microcephaly, that has resulted in the children with special needs. And this little poster shows the common Edie's breeding sites around a house. And we've used this to design a game, an educational game for children that teaches them to destroy mosquito breeding sites. It's called a Zapaquito. But I really need a good PPP to take this to scale. We need a game company like King.com or SeriousGames.com, and we need an academic partner. We have the academic partner, but we haven't got the game company to take it to scale. Now here's another shocking one. Is this boy fat because he's greedy? Because storms have blown down his island's agriculture so many times that it's just cheap food imports that they're surviving on. And I think that's part of it, and I'd love to have a collaboration on scholarship to go back the last few decades and see what happens to nutritional security after the big storms. It's not only storms, as John said, drought is a challenge for us, and in the Northern Caribbean, take Jamaica, in 2015 they had a severe drought. That whole band, Belize, El Salvador, Jamaica, serious drought. That also is part of the manifestation of the change. To respond to all of this, partly our job as CARFA is to try to foster a regional resilience and develop partnerships around it. And over the last couple of years, intensified effort on that, put together an expert panel chaired by myself and Professor Lichfield from Tulane and John Balbus and others around this, as we try to internally in the region, work with external partners to figure out how to tackle this. And so in summary, what we found is that there are quite a lot of programs, but they're not joined up, and there are a lot of gaps. And biggest gap is in awareness. People don't know, or health workers in particular, have insufficient awareness that this is happening and the serious implications for us. We've come up with a climate roadmap, and the goal is really to reduce the impact of climate change by engaging or building a health sector-led alliance to take measures with co-benefits for health and sustainability. And that's we're trying, John and I have been playing with the words, trying to encapsulate what it is we're trying to do. Getting the word out to raising awareness is important. So this year in June and in September, we'll be taking policy papers on climate and health to the chief medical officers of the region, and then the Council of Ministers in September, because they've never received a paper on that. And then working on the different things, community resilience, the hospital, health facility resilience, built environment, biking and walking. We have a serious problem with non-communicable diseases. If we could switch more biking and walking, it's good for the planet, it's good for health, and it's good for energy security. We spend a lot of money on energy in the Caribbean. And I think that's probably, this is an example of some of the PAHO Smart Hospitals work. So this is what some of the things that people are doing. This is a joint bulletin we put out with PAHO and the Caribbean Institute of Meteorology and Hydrology to give some warning to what's going to happen. And these are some of the actions. That's probably too hard to read, but I was talking about some of them a moment ago to get the word out and to get it. We have, in the region, we have a SEDEMA, which is like your FEMA. We have us. We have a Crime and Security Agency and an Aviation Security. And we just worked out a standard operating procedure between ourselves for how we respond to emergencies. Our next meeting of our panel will be in St. Kitts and Nevis in June. I think I better stop there. I've been talking too much. Thank you very much.
And our next speaker will be Dr. Wim de Villiers.
So good morning. I'm Wim de Villiers. I'm the Rector and Vice Chancellor of Stellenbosch University. It's a real pleasure to be here, especially as this is Stellenbosch University's centenary year, and it's a real privilege to also be a co-host of this CUGH conference. So I'm going to be talking to you about a specific issue, and this is the water crisis in the Western Cape in South Africa, and then coupled with that, our institutional approach to this water crisis. So it's a little bit coming from the macro to the very micro, and how did we actually engage with this problem. So it is also of importance, I think, to note that I'm a gastroenterologist, so we tend to keep things a little bit basic and concrete, so I'm really going to focus on some of the very institutional matters. So to give you an overview here, it's sobering to think that 783 million people worldwide do not have access to safe and clean water. This slide shows you South Africa, but in a different sense. It shows you its major catchment areas and rivers. And what it tends to, or what it illustrates, is that South Africa, over the decades and centuries, have cycles of droughts. We're used to having droughts. It is a drought-stricken country at times, and it has a water-constrained economy. And 8% of the land, as you can see here, actually supplies 50% of the water. You can see in the bottom left, you can see the Western Cape. And there is, the Western Cape is a winter rainfall area, but it is currently in a water crisis, a drought situation. And this, together with two other provinces, the Northern Cape and also the Eastern Cape, have now been declared national disaster areas, and that they qualify for drought relief. I think coupled to this is a term that I also came to be familiar with, which is namely it's hydropolitics. And hydropolitics imply that the government, the national government, is very concerned about potential job losses in vulnerable farming communities in these areas, and the subsequent move of these poor workers to urban areas. So the other point is, what about Cape Town and the city of Cape Town? And I show you a dashboard here. The city of Cape Town provides water to about 8 million people. The drought situation there has been aggravated by increasing urbanization over the last couple of decades. Climate change, we saw a very vivid example shown by John here that showed the rise in global temperature. I'm definitely going to use that slide in talks going forward. And also, as he showed, the warming of the continent. So as you can see here, the Cape Town dam levels in the recent month showed a dam storage level of 23.5%. And the average daily production that's required is 527 million liters per day. So this has resulted in a level, what's called level 6B water restrictions. What does that mean? That's 50 liters per person per day, and the requirement is that one would need 45% saving on water consumption. So on a personal basis, 50 liters per person per day means that you need to save all the water that you shower with, that you need to take showers of less than probably a minute and a half, and that you should be very careful about flushing the toilet. A little bit more about that later on. So this slide shows the Western Cape water supply system and the current situation. In the top left, that graph shows the steady decline in the percentage of water stored. But as you can actually see there, since these measures, water-saving measures were instituted, there's been a little bit of an increase there at the right. At the bottom left, you can also see the green part of that graph shows the usage by agriculture, which is a very important industry in that section. So that's about 29%. And then on the right, you can see it's a map of the Western Cape with Cape Town there and the different dams that contribute to the Western Cape water supply system. We know there's a large seasonal climatic instability, but as I mentioned before, there's a major problem in the agricultural sector. This is an agricultural rich area, and in terms of unemployment, we're certainly very worried about that. What this has resulted in is that the city of Cape Town has, in somewhat apocalyptic terms, announced a day zero in terms of water supply, and that is when the taps would run dry. And what are we going to do about that? So, being the head of a academic institution, now to the very micro level, what has actually been our response plan to this drought and to provide some solutions to this issue? So if one looks at the water consumption of our campus, of our university, we have about 32,000 students, 3,000 staff. And our daily water consumption is about 2.5 million liters per day. And that's about what an Olympic-sized swimming pool contains. This is about 10% of the town of Stellenbosch's daily water consumption, which is 25 million liters per day in total. And we're an example of a typical university town, of a town-gown community. So I'll start with the good news first. So as you can see here on this slide is what we've actually, through our measures that were instituted, what we've achieved is, in comparison to 2015, 2016, we've actually come up with about a 40 to 50% savings on water consumption. The top graph there shows the baseline figure, and then the middle one shows measures that were instituted, the effective measures that were instituted last year, and the bottom one is where we are at the moment. So we've achieved some success in really mitigating some of the water issues. What are some of so now let's come to the nitty-gritty. What were some of the specific interventions? We went first with some of the low-hanging fruit. So as you can see with the inverted pyramid on the right here with a lot of emphasis, so there are three ways. It's reduce, it's reuse, and looking at alternative sources, with the emphasis really on reduction. And reduce, efficient fittings, pressure reduction, reuse, rainwater harvesting, grey water reuse, and wastewater treatment of effluent. And then alternative sources, groundwater abstraction, so this is making use of more boreholes, and also accessing aquifer storage, dam water, and river water. But it's been very interesting over the last 18 months to really note there's been a paradigm shift in where one regarded water just as a resource, not even to be thought of, just to a resource that is really extremely valuable and should be carefully nurtured. So that the paradigm shift really occurred from on the left to when one thinks about conventional water management system to a sustainable water management system where we need to reduce the potable water demands, we need to reuse stormwater, we need to reuse wastewater, we need to look at aquifer storage and recovery, we need to increase infiltration and really reduce wastewater discharge. So it's a multi-pronged approach for us to result in decreased water usage. So the actions taken, number of them. Reduce water consumption. So the awareness campaigns, responsible use of water, retrofit shower heads, reduce shower times, and as a gastroenterologist, in terms of my most favorite phrase that I can use when I speak to students and staff is with regards to toilet use is, if it's yellow, let it mellow. If it's brown, flush it down. So reduce leakage and wastage. There's a war on leaks, pressure reduction, alternative water sources, as I've mentioned, and also, very importantly, reuse wastewater. Some of the immediate interventions: leak detection, electronic metering, as I mentioned there. One of our engineering professors really got quite a bit of media exposure because of his, he launched a smart water leak system, and that became, it's very efficient and very popular. It's now also been instituted in more than over 200 schools in the Western Cape, and actually has helped these schools to detect leaks and decrease their water consumption by more than 50%, with significant savings for these schools as well. So these were some of the immediate interventions that then resulted in that saving that I showed. So that this is the current situation before we started some of these interventions, and what that has resulted in a variety of ways. The different decreases in potable water, different decreases in shower usage, etc., is that we're actually looking at it probably about as top right there, a 63% saving. But we are, it's, this is not the sort of thing that when you draw up a budget for an academic institution, and where what's really at your core is teaching and learning and research, and you don't really necessarily bring this into the equation. We've also, in this last slide, have had to look at some ways in which we're sinking more boreholes to get more water from there, but how do we actually bring this into the system? And this is an example of a container, that it's a containerized borehole water treatment. So there's treatment of water from the borehole that you can put into the distribution network directly. But we had to buy about 5 of these, and they come at a cost of $1.5 million. So that's something that we certainly had to take care of in our budget. So in short, what I hope to show you is to present to you some solutions in a micro, in our specific institution, that our institution and our community that we try to adopt in really facing and with this very, very significant problem. But what it has actually led to is over the last 18 months, 2 years, an entire different way of looking at water, and a different way of dealing with water usage. And it's a complete paradigm shift, and I don't think as a community we'll ever look at this in the same way again. Thank you very much.
Thank you very much. And our final speaker will be Dr. Kim Knowlton of Natural Resources Defense Council and Columbia University.
Thank you, John. And thank you, everyone, for being here early on a Sunday morning, but to talk about something that's really quite important to us all. So I'm going to offer some brief points, hopefully, so that we can get to a discussion and a question and answer session quickly. I'm a health scientist. I have those 2 hats that John mentioned, working at an advocacy organization that works to protect the earth, protect human health, quite an ambitious set of goals. And I also am in the climate and health program at the Mailman School of Health at Columbia University. So the question here is, how do we move all of this super important, fantastic evidence that my colleagues on the panel and others have brought together? How do we move evidence into action? That's a big part of what I hope to help all of us do. So we see this evidence, we hear that climate change is threatening our health locally, here and now. It's a global community. It's not just about climate change affecting people in a time and place distant. Not at all. I had the opportunity to work on the 3rd U.S. National Climate Assessment on the Human Health Chapter with a number of colleagues who are here and others, a fantastic author team. And that was one of our big findings in the National Climate Assessment, that this is a set of here and now health issues for people globally and right here in the U.S. It's interesting to note that in some recent surveys of physicians, quite a few in the US, over 2,000, that 2/3 of physicians are saying already that climate change is affecting the health of their patients. And I think with recent extreme weather events globally, including here in the US, people are learning a lot about what climate change looks like from their own experience, in addition to the perhaps more academic work, and really connecting those dots between climate change and health, I think imperative. And I think it's a part of what brings us all into the room together this morning, early on a Sunday morning. So I want to offer some brief points on these, what I think of as 4 pillars in how we can move evidence and awareness into action. There's science, there's education, there's law, and there's very much the power of people. What is it that brings us together this morning, that makes us a community of people working both in a university setting, in our own communities, in our own families and households, to really try and advance positive protective action on climate change, because we need climate solutions. That's what I'm here to offer as some thinking. But we'll talk about that more, I'm sure. As my colleagues have mentioned, there have been excellent, very solid evidence and reports in recent years, in the last 10 years, a number both looking at a U.S. sort of framed storyline, the national climate assessments in the U.S., both the 3rd and the 4th, which has now been partially released, is still underway. Internationally, the work of the Intergovernmental Panel on Climate Change, the work of the World Health Organization and World Meteorological Organization, to bring forth reports that tell us in detail what do we see in terms of observations and what is projected for the impacts of climate change. More than ever, we also now understand that some events are simply possible to attribute to climate change, events that would not otherwise have happened without the effects of human-caused climate change. Extreme heat in 2016 globally and in Asia, a large area of extremely warm water in the northern Pacific that has had a lot of impact on global climate. Those can be attributed now to the effects of climate change, and that's quite important for us to continue that work. I just want to mention that at the Natural Resources Defense Council, we've had quite a bit of success in trying to make global climate change a more local story and take climate change's effects on the environment and bring it down to the state, to even to the county level. A series of maps that NRDC launched in 2011 and that we continue to update has really given people a sense of what's happening in their own backyard. And the URL is pictured at the bottom of the slide. But I think it's also important to note that we offer information on what's happening at the state and local level in terms of adaptation and preparedness and what people can do to raise their voices and demand more action to protect ourselves against climate change. From time to time, I will participate in educational briefings on Capitol Hill with some of my colleagues, and back in 2009, I was involved in such a briefing in the Senate office building, the Hart building that's pictured on the left, and we looked up at the TV monitors that are all along the hallways of the office buildings, and we saw this image on the right of some really dramatic flooding happening in North Dakota at the time, the Red River flooding. And we asked ourselves, how much does that cost? We realized we didn't know. We realized that there was no estimate at the time for what extreme weather events that are happening right now in the US are costing in terms of health impacts. How does extreme weather of types that are being fueled by climate change translate into dollars and cents, in addition to human pain and suffering, which we want at all costs to avoid? So NRDC partnered with economists at the University of California, and we looked at just 6 events that have already happened between 2002 and 2009. And we were, frankly, a bit surprised that the total for the health-related costs was $14 billion. 14 billion. These are costs that are typically unassigned and unevaluated when we think and talk about the impacts of climate change on society, and that needs to change. We need to have an appreciation that it's costing us societally hundreds of thousands of encounters with the US healthcare system, and take that appreciation into the future. So, armed with the evidence of my colleagues on the panel, with the scientific community, with the research community, how do we move that into an educational setting that you are all intimately involved in? With my Mailman School of Public Health hat on, I have helped Mailman since early 2017 to organize and lead the Global Consortium on Climate and Health Education. This is a follow-on to a then White House and consortium of many deans of health profession schools, sort of an initiative that began at COP21, the Conference of the Parties 21 in Paris in 2015. Following on to their commitment to put climate and health education into their schools, Mailman has been successful in gathering a consortium of now 162 member organizations in 28 countries. The URL for the consortium is at the bottom of the screen. We invite you to visit us, to think about joining. This is an effort to assure that the next generation of health professionals will have climate and health training and a community of practitioners that they can tap as they work into the future. So thinking about the environmental side of health and human health, environments like this, and of course there's many others that we want to protect, that we need to protect, because this is the foundation of our own health. So even as we look at pristine settings like this, we must admit that there are moves, there are times when there are forces that serve to threaten the stability, the environment that we depend on, and indeed environmental degradation and human health threats are a great issue now. In the last year plus, there have been a great many executive orders here in the US that in fact threaten health in the environment. So I want to point out that besides science, that first pillar of moving evidence to action, there's law. And NRDC has very skilled attorneys as part of our resources and part of our staff. So far, the attorneys have brought 56 cases against the current administration to challenge anti-environmental and anti-health initiatives. We've been successful so far in a number of those cases, but there are many more pending. So it's important for us to remember that the law, in addition to science and education, is a pillar of what we can do. There are many other organizations and agencies and governments worldwide that are using the law to try and fight climate change and reduce the sources of, and indeed provide more adaptation for its effects. Because engaging people, that's sort of the fourth pillar, trying to make sure that people and communities that are being affected dramatically by climate change right now become part of the conversation. It's not just the exposures that are increasing, but it's people's vulnerability too. So how can we let people know that there are many possibilities, both reducing climate change at its source by reducing carbon pollution and by adapting, preparing better. This graphic pictures some findings from an NRDC report that came out last September of 2017 that shows us steps that can be taken with technologies that are available now to move toward an 80% reduction in the US's greenhouse gas emissions by 2050. It's quite possible. The health and environmental benefits will outweigh the costs of instituting these steps. So success and solutions to the climate crisis are indeed possible. But how do we prepare better for the effects that we're already seeing that at this point are to some degree unavoidable? I want to share with you just a few brief points from a project that NRDC has been involved with partners in Ahmedabad, India. And now I'll talk a bit about how this effort has spread beyond the city of Ahmedabad, which is located in Gujarat state in western India. We know that climate change is fueling more extreme heat waves across the world. We know that people, as in Ahmedabad, are already dying, unfortunately, when heat waves strike. In 2010, Ahmedabad experienced a historic heat wave that caused hundreds of people to perish. The city leadership at the Ahmedabad Municipal Corporation said, no more. This is our clarion call. We want to do something to protect the people of Ahmedabad. So with some help from NRDC, but really the instrumental partnership and action and ownership by the people of Ahmedabad, there's a heat action plan that was put into place with an early warning system that did not previously exist. As Madeline mentioned, it is not universal that there is advance notice of extreme weather events, and that was the case when we began to work in Ahmedabad. But with an early warning system for projected heat waves, with a lot of public outreach and partnership with the media, and with increased capacity for health professionals to work with the people of Ahmedabad to treat heat-related illnesses before they progress to mortality, there's been a dramatic change in what happens during heat waves in Ahmedabad. There's been enormous engagement with the people of Ahmedabad, which I think good old relationship building is really important that we not forget. You see here the women of Ahmedabad marching through the streets within an awareness-raising parade. On the right, you see the mayor and other city leaders of Ahmedabad painting rooftops white to reduce the urban heat island effect, which just makes the heat wave effects much worse. In Ahmedabad, that initial work has gone from one city to now 11 states and 17 cities who have adapted their own heat action plans to their own local needs. So scaling this type of work is indeed possible, but scaling the conversation that we're about to have and are having here too, moving from awareness to action, is entirely possible. And I think it's important that besides science and law and people, there's the power of education, and all of you hold a lot of capacity yourselves to make that a reality where you work. So with that, and with a bit of reminder of all the inspiration, that it matters a great deal what we do in seemingly small initial groups, it really can ripple like a stone thrown into a pond and have huge effects across much wider parts of society. So thank you to all of you here and to all of my partners, both at NRDC, our partners, and at the Mailman School of Public Health at Columbia University, from the Dean, Linda Fried, and all of my colleagues there, and you. Thanks for listening, and now I can't wait for the discussion and hearing from you a bit. So thank you.
Thank you, Kim. And can we just have a round of applause for 4 over there? Really great presentations that have given us a lot of different perspectives. We're going to take questions now from the audience. We have microphones in all of the aisles. I'm going to look over this way because everybody else is over here. But before, as people line up, I just wanted to point out pick up something that I saw on one of the slides, and I'm going to ask each of the panelists to just answer this as we get ready to take the questions. So, James, you had a slide that said health professionals are sleepwalking. You didn't say that, but I saw it. And on our satellite session, we also talked a little bit about this disconnect, the fact that we have knowledge, we have things that we can do, but the actual translation of that knowledge into action at the level of the local health departments and the health professionals is lacking. So I just wanted to ask each of you if you would just give us, and I think some of it may be sleepwalking. I think in many cases people are overwhelmed by the amount of information and by the enormity of the problem and aren't quite sure what they can do and where to start. So if everybody wants to just offer up one idea that the sleepwalkers among us, the overwhelmed among us, waking up tomorrow might be able to start to embark on the actions. We've heard this array of actions we can take, but what would be the one thing that you would have people as individuals do? And why don't we just go down the line, unless Madeline.
Thank you. So just in terms of what we can do now, which we couldn't do 10 years ago, 15 years ago, health surveillance systems have developed enormously in the last decade, partly in response to the MDGs. When I started my career in West Africa, nobody looked at the health systems data for anything. Now we're building systems where the health systems data is coming in, it's being centralized, it's being analyzed, people are starting to use information, and that means that health data can now be tied in to external drivers. You can see what the external drivers are and how they're impacting on the health data itself, and that is a motivating force for the health sector to start to act. They can see what's driving the health outcomes that they have.
Thank you.
I offered one in my talk that our region, the chief medical officers and the ministers of health have never received a policy brief on climate and health, and it's our intention to do so this year. That'll be sensitization at a high level, and that sensitization on policy will include the development of education for climate and health. So all the partners here who have those programs, please, I'd like to talk to you to jumpstart what we are. The data, though, do prove are a good area too. We have lots of data for decades, but we've hardly ever analyzed those in relation to climate events. And so there's a whole bunch of research that can be done in that regard, which will also help to show the connection.
Yeah, thank you very much. Sleepwalking, I think, is a reasonable term. I was trying to think of how to address this, and I can do it twofold in terms of our medical student curriculum and how we teach our medical students. I think we, at least in the South African sense, it's still very much, it's about an individual approach to problems rather than a system thinking approach to issues. So I think that would, and it's also a focus in terms of curative rather than preventative the curriculum. So I think in that sense that the sleepwalking part, that one tends sometimes not to see the big picture as it is. The other point, I think, talking about sleepwalking, I mentioned the Day Zero campaign. Even though it was very apocalyptic and has come in for a lot of criticism, you know, the taps are going to run dry on day such and such. It was a very, very effective way of marshalling public awareness and to really get it really in the public domain as to what one should do. So sometimes one perhaps has to do things like that to get the interest.
I'm going to stay in the theme of make climate change local. I would say find the local champion, whether it's someone who really wants to put climate change into the curriculum, who knows a great deal, who knows people who know, and just talk about it at every planning session, at every curriculum planning session, every municipal planning session. Make it a topic that's part of every discussion, and bring the champions along so that there's a group of those champions who appear every place, because the urgency of the issue can't be forgotten. And it's easy, in terms of the comment about sleepwalking, I think, to forget that. So the champions can help us remember.
Great. Thank you. And not a coincidence that your answers have been along the line of your framework: science, education, educating the lawmakers, engaging the people. So wonderful answers. Okay, what I'd like to do is at least take 2 or 3 questions at a time. So why don't we start at this microphone?
I'm Tara Casebold. I'm a PhD student at UNC, and very interesting talks and very interesting conversation. I've been seeing a lot of think pieces recently about the impact of climate change on our basic resources like water and food, and how that is going to potentially increase conflict in some regions, and how that will further degrade our healthcare infrastructure and other infrastructure, which will then further decrease our access to things like water and food. And I was wondering if you guys have seen anything related to this in your research, because all I've seen is mostly think pieces and not actual scientific research on this.
Great, thank you. Question, Peter?
Thanks, John. Peter Kilmarks from Fogarty, and just want to thank all of you for a really terrific panel, really highlighting the diversity of the challenges and the geographic diversity. Reminded of a little sign I saw in Dominica. My sister was in the Peace Corps in Dominica in the Caribbean, and it said, "In our island by the sea, please don't flush for just a pee," which sounded like the Stellenbosch sign. But I had a question, and maybe especially for Dr. Knowlton, but for anyone on the panel. What do we know, how are we monitoring the population knowledge and attitudes about climate change and related practices? And what does the research tell us about what is most effective to change knowledge and attitudes and practices, or what research is needed? Thanks.
Great. Thank you. All right, why don't we pause there? So we have a question about the role of climate change in exacerbated conflict, and how the science of the resource constraints and those impacts on health, and then this question about the social science of knowledge, attitudes, and beliefs. And does anybody want to take the conflict question? No?
So of course, climate is an exacerbator, if you like, of other threats. So it's rare that just climate itself is driving something. And particularly for conflict, there are many issues that drive conflicts in different regions. But we've seen, I think, particularly for the Syrian conflict, how droughts preceding the conflict mobilized populations from the rural areas into the cities and started to cause a lot of social disruption. And I think that that impact on rural to urban migration as a result of drought is a really significant issue, and droughts are a huge issue in all parts of the world. I think around the food supply system, we've also seen the 2008 climate events that resulted in the major food spikes, price spikes. And that price is a huge issue in terms of nutrition, particularly in poorer communities and in urban areas. So I think that the evidence is coming in directly now on the role of climate and nutritional crises and then political crises being associated with that.
Thanks. Is this on security or change tack?
I think the question was about the interplay between scarcity of resources, conflicts that arise of that, and then the knock-on effects of access and availability of those resources that is worsened by the conflict.
Well, one of the things that we've seen is after all the disasters, you get security breakdowns. People become very aggressive, or they become very passive and depressed and out of it, but then they loot, and that can be as bad as the hurricane. The amount of damage that can take place as a result of that. So, as I mentioned, our chiefs of security and commissioners of police this year will take that as and they've never taken that as an agenda item before. They try to figure out how to prevent crime, but they've never thought about climate and what it means for security. And these big hurricanes are always accompanied by, and therefore you need to plan for. In terms of Peter's question about knowledge and awareness of people, at least in our region, I think if you ask the man in the street about climate change, they may understand those words, but they have no idea what it really means. And if you ask them health community, it may be a little better, but not much.
Just to add to that a bit, there's a lot of polling that happens by many different groups, looking at the response of both the public, sometimes along party lines. The trend is that more and more people are engaged on climate change. I won't speak to the party differences, but I think the work of Ed Maybach and his colleagues at George Mason University has shown that the health framing around the messages of climate change has been quite successful. At NRDC, we find the same thing to be true, which is part of why we're emphasizing the health effects as a driver to make action an imperative to protect and to reduce climate change at its source. So I think that the health framing is, the assumption is, and polling seems to bear out, that it is a way to reach people because there's an implicit engagement around health protections.
Great. Why don't we take a few more questions? We still have folks at the microphone over here.
Hi, my name is Maya Maxim. I'm a pediatric hospitalist from the University of Hawaii. And so as an island community, we are on the front lines. We have the worst per capita homeless rate in the entire country in Honolulu, where I live. We're not that big a city, so in absolute numbers, it's not, but by per capita it is. We also have had tens of thousands of people coming in the last couple of decades particularly from the Federated States of Micronesia and from the Marshall Islands, seeking a better life in Hawaii. Obviously it's multifactorial, but it's certainly in part related to climate threats, and we are under threat as well. Some of our maps project large portions of our city being underwater within 50 years, and that will only exacerbate health, housing, and many other issues. So I wanted to share that because I think it's not very well known what the situation is in the Pacific as much. And I also wanted to say that over the last couple of years, I've gotten very involved in local politics and also in advocacy on the national level. And I wanted to encourage, I can't speak so much to people from other countries, but to people here in the United States, the counties, the cities have a lot of power. And for me as a physician, I found that my voice is much louder and much more powerful than I had ever given myself credit for before. So I wanted to share that and to thank you all for helping to support the voice that I am able to have with your science, with your, with your work, with data, because having that as ammunition when I walk into my senator's office or when I go into local meetings of the Democratic Party is incredibly valuable, so thank you.
Thank you for that comment. I was very struck that the Marshall Islanders are being evacuated from their island because of the threat to it. And I met one of the health department heads for the state of Arkansas. And in fact, Arkansas is having a huge problem right now because communities of Marshall Islanders come in and they have multi-drug resistant tuberculosis, and they're coming into communities where there's employment for them. And so health departments that had not had these problems are now dealing with problems that they had to see. And I think this is just one example of a problem that's probably occurring globally, not just within the inner United States where we take in refugees, but refugees all around the world.
There's a very high burden of both infectious and non-communicable diseases.
Yeah.
It's a much greater proportion of the patients I care for than by population demographics.
So it gets to that idea of resilient systems ready for the incursion of people with problems that had not been seen. Yeah, thank you.
Hi there, my name is Liza Donna, and I'm an emergency medicine physician and a medical toxicologist. I work at Washington University in Monsanto. My question for you is, since agriculture has one of the biggest carbon footprints in the world, and food security seems to be very much like water security, people kind of take it for granted. How are you all working with precision agriculture and modern agriculture to optimize the inputs and minimize the carbon footprint?
Okay, thank you. Let's take another question.
Oliver Fine from Weill Cornell. The panel has not mentioned anything about the military. And in terms of a carbon footprint, I was wondering if anyone has actually examined that. And secondly, it is one of the largest components of the federal budget in the United States. So I think that we should have some focus on its contribution to the climate crisis.
Thank you. Thank you for that question. And why don't we take one last question and then we'll finish up the panel. We are running out of time, so.
My name is Nathan Utman, and I'm a Global Health Fellow through the HEAL Fellowship at UCSF, which I'm proud to say places many fellows in local underserved communities domestically, along with internationally in underserved communities. So my question is basically whether or not there's possibly some low-hanging fruit, so to speak, right under our noses that maybe we could mobilize around to see about leading by example, practicing what we preach. A little more context about that. Currently, I'm working in Liberia for a health NGO, and so I see a lot of health NGOs that are partners to the government, which I think is representative of international impoverished nations. And I'm not aware of anything comparable to what I saw on a slide that is active at trying to encourage governments to implement best practices for climate, environmentally friendly policies. I'm not aware of anything comparable to that for, let's say, the NGO or government partner sector for health organizations. Also, at the satellite session, Dr. Patz presented about the health benefits for bike-friendly cities. But I'm also not aware about any survey that asks us as individuals whether we actually take that action of, for example, biking or walking if we live within 2 miles of our workplace. And the last point is, I believe at last year's CUGH conference, somebody raised the point of whether or not we, as CUGH, are in fact as green and sustainable and climate friendly in everything we do, top to bottom or not. I may be ignorant, but I've not seen or heard that. Thank you.
Great. Thank you very much. So we have 3 very different kinds of questions. One on agricultural solutions to the problem, different ways of doing things differently in agriculture to mitigate the carbon footprint of agriculture. a question about the carbon footprint as well of the military, as well as the financial burden that military budgets place, and a third, really mostly a comment about walking the walk, but walking the walk in different places, the NGOs that we belong to, and we as health professionals. So I'm going to ask one person to take one of those. Does anybody want to speak to the agriculture?
Yeah, thank you. I was also thinking about the knowledge on climate change aspect, and together with agriculture. And it's certainly, when I specifically apply the water crisis issue in the Western Cape, it's nothing like a specific issue that focuses the mind. So that has, and it affects everybody across society, rich and poor. So certainly that has allowed for a segue into discussions on the effects of climate change. It's also allowed for discussions into alternative sources, for example, desalination. And also, I mentioned aquifer access, but some of the negative side effects of aquifer access. But particular to agriculture, what it has led to is in a decreased access for agriculture to water has really required many farmers, both small and large scale, to in a different way look at how their utilization of water. And I think they've actually managed to do that quite successfully. So in that sense, it has changed practices significantly. But another aspect which I think is very worrisome is the effect that this has had on employment of farm workers in the system, and unemployment there, and the effect of urbanization, of movement to cities.
Thank you. I am getting the absolute hook, so I think we are going to have to close this now, and what I'll ask is that those of you who are interested in these questions can come up. We can have this panel discussion continuing informally, but I'd like to adjourn this one more time. A round of applause for these wonderful panelists. And thank you to the audience. And again, we welcome conversation now during the break. Thank you very much.